Hey everyone, and welcome. If you're a medical microbiologist, you're in the right place. Today, we're doing a deep dive into a pathogen that is incredibly significant clinically, but, well, it's often forgotten: Fusobacterium necrophorum. Everything we're about to cover is based on a comprehensive Gemini deep search. And for all of you who love to check the receipts, all the sources are in the notebook linked below. Let's get into it.
You know the drill. A teenager comes in, raging sore throat, tonsils are a mess, and the first thing on everyone's mind is Group A strep. But what if our go-to diagnosis is wrong? What if the real culprit is hiding in plain sight, an anaerobe that our standard tests are designed to miss completely?
Just look at this data. It's pretty shocking, right? For adolescents and young adults, Fusobacterium necrophorum isn't some rare exotic bug. We're seeing it in 10 to 21% of pharyngitis cases. That often puts it ahead of Streptococcus pyogenes. So the leading cause of a bacterial sore throat in this group is a bacterial we barely even look for.
Okay, so here's our roadmap for today. We'll start by getting reacquainted with this forgotten foe. Then we'll hit its microbiological profile and the diseases it causes. After that, we'll look at how to diagnose it in a modern lab, tackle the really critical divide in treatment guidelines, and finally, talk about prevention and where we go from here.
So let's jump right into part one, a formidable, forgotten foe. We're going to try and understand why this pathogen seems to be making a comeback.
So what is this thing exactly? Well, at its heart, Fusobacterium necrophorum is an obligate anaerobe. It's a gram-negative bacillus, doesn't form spores, and it's actually a normal part of our oral and gut flora. But that's the Jekyll and Hyde part. Don't let its commensal status fool you. When it gets the chance, it transforms into a seriously potent and invasive pathogen.
All right, moving on to section 2, the microbiological profile. Let's dig into the taxonomy, the subspecies, and the virulence factors that make this organism so nasty.
Okay, so there are two main subspecies you need to know about, and they're pretty different. Subspecies Necrophorum, that's primarily the animal pathogen. It's highly virulent, packs a powerful leukotoxin, and looks like long filaments under the scope. What we're usually dealing with in human infections is subspecies Funduliforme. It's considered less virulent, but as we'll see, less virulent is a very relative term.
Now let's talk about its weapons. This thing is armed to the teeth. The star of the show is its leukotoxin. It straight up kills neutrophils and macrophages, effectively knocking out our immune system's first responders. Then you've got its LPS endotoxin, a hemagglutinin that gets platelets to clump together, which is key for Lemierre syndrome, and a cocktail of enzymes that just melt through host tissue. Which brings us perfectly to section 3, the spectrum of disease. With an arsenal like that, what does it actually do to a patient? Let's trace its path from what looks like a simple sore throat all the way to systemic sepsis. And here it is. This is the absolute core of the diagnostic challenge. A patient with Fusobacterium necrophorum pharyngitis has a fever, a nasty sore throat, exudates on their tonsils. They look, for all the world, like they have classic strep throat. So what happens? You run a rapid strep test, it's negative, and the infection gets written off as viral. No treatment. And when it goes untreated, it doesn't just go away. This number is, well, it's staggering. 23%. Fusobacterium necrophorum is the most common bacteria we pull out of peritonsillar abscesses. It's not just a bit player in deep neck infections, it's the leading actor.
And that can lead to its most feared complication, Lemierre syndrome. It's a terrifyingly predictable cascade. Step 1. It starts as a basic throat infection. Step 2. The bacteria break out, invading the deep tissues of the neck until they hit the internal jugular vein. Step 3. It triggers an infected blood clot, septic thrombophlebitis. And finally, step 4. Pieces of that clot break off and travel through the bloodstream, seeding infection all over the body, especially the lungs.
So how on earth do we catch this thing? Let's get into section 4, modern laboratory diagnosis. This is all about the challenges of identifying such a fastidious foe.
Your gram stain is often the first clue. You'll see these pleomorphic gram-negative rods. Now culture, it's tricky. It's an obligate anaerobe, so you need the right transport and incubation. On the bench, indole and lipase positivity are key biochemical markers. And of course, we have our modern tools. MALDI-TOF is great for rapid ID, but only if your database is up to snuff. And PCR is super sensitive, but it can also light up for asymptomatic carriers, which complicates things.
All right. Let's shift gears to what is arguably the most critical part of this entire discussion, Section 5, the guideline divide. This is where the microbiology we do in the lab directly impacts patient safety at the bedside.
If you remember one thing today, make it this. Fusobacterium necrophorum is intrinsically 100% resistant to all macrolides. That means your Z-Pak, your clarithromycin, they do absolutely nothing. This is non-negotiable and it's life or death information, especially when you're treating a patient with a penicillin allergy.
The good news is we have great data on what does work. The European Committee on Antimicrobial Susceptibility Testing, EUCAST, gives us very clear breakpoints. As you can see, it's generally susceptible to things like benzylpenicillin, piptazo, meropenem, clindamycin, and metronidazole. So we have plenty of options, as long as we know what we're fighting.
And here's the problem. It's a huge one. International recommendations often lean towards something like amoxicillin clavulanate to cover all your bases. But then you look at the Dutch SWAB guidelines for pharyngitis. They recommend narrow-spectrum penicillins. And here it is. For penicillin-allergic patients, they recommend macrolides, the exact class of antibiotics that we know is completely useless against Fusobacterium necrophorum. And this is the smoking gun, a direct quote from the source material. The Dutch guidelines for treating a sore throat do not mention Fusobacterium necrophorum, not once. So imagine you're a clinician in the Netherlands. You follow your guidelines perfectly for a teen with a penicillin allergy, and you prescribe a drug that is guaranteed to fail, potentially paving the way for a life-threatening complication.
Now, it's really important to make a distinction here. This is mostly a disease of adolescents and young adults. In younger kids under 14, it's much less common, which is why pediatric guidelines are so heavily focused on Group A strep. When this does cause serious disease in a child, treatment is of course weight-based, usually with IV regimens like ceftriaxone plus metronidazole.
So, all of this leads us to our final section, prevention and the path forward. And really, this is a call for all of us to be more vigilant. When we talk about infection control here, it's a bit different. This bug comes from our own flora. It doesn't spread from person to person. So the single most effective prevention strategy is actually clinical. It's secondary prevention, treating that initial sore throat quickly and, most importantly, correctly. In the lab, sure, it's BSL-2, but the real infection control happens in the clinic with a prescription pad. So I have to leave you with this question. Are our current guidelines, with their laser focus on strep, creating a massive and dangerous blind spot? By not even considering Fusobacterium necrophorum for a teenager with pharyngitis, are we accidentally letting this forgotten disease make a deadly return? The evidence we've seen today suggests that we very well might be. And that's our look at Fusobacterium necrophorum. If you found this helpful, please subscribe for more explainers on the microorganisms that matter. We would genuinely love to hear from you in the comments. What are your experiences with this pathogen? What are your local guidelines like? Thanks so much for watching.